Hello guys, so we'll start another topic, patent ductus arteriosus. So what is patent ductus arteriosus? It is the persistence of normal fetal channel connecting aorta to pulmonary artery. So this is a normal fetal channel which connects aorta to pulmonary artery. The communication is between left pulmonary artery and aorta distal to origin of left subclavian artery. So you understand there's a connection between artery, pulmonary artery and aorta. And then epidemiology, it is more in males than in females, and it is seen in 5 to 10% cases of all CHD. Mechanism. So after birth, lungs expand and oxygen content of blood increases. After cord is cut, there is sudden shortage of prostaglandins from placenta and the PDA closes. This happens normally. So due to prostaglandins, the patent ductus arteriosus closes, and but here it does not. In PDA closes functionally by 24 hours after birth in full term. PDA closes anatomically by 23 weeks. मतलब functionally it closes after 24 hours, but anatomically it closes 23 weeks. Unlikely to close or reduce in size after a month in term babies. So if there is uh, time more than 1 month, then that means it will never close. So preterms may take longer, up to 1 year. So that is normal in preterms, but in full terms, the duct should close within 1 year. Prostaglandin mainstay patency of the duct useful in duct dependent cyanotic ACHD. So prostaglandin mainstay patency of the duct. So in term babies with PDA, there is deficiency of both mucoid endothelial layer and muscular media of ductus. So there is deficiency of two things in PDA due to which the duct is persistent. There is mucoid endothelial layer and muscular media of ductus. Two things. What? Mucoid endothelial layer and muscular media of ductus. In preterms, PD is structurally normal. Patency is due to hypoxia and immaturity. Hence, preterm baby response to prostaglandin inhibitors like indomethacin, while term babies require surgical closure. So, if you give indomethacin to PDA patients or preterm PDA patients, they will show response. But for term babies, there is deficiency of mucoid endothelial layer and muscular media of ductus. So, you'll have to do surgery. Do you remember mucoid endothelial layer? So, endothelial layer, mucoid, absent. Muscular media of ductus, absent. Muscles absent, endothelial layer absent. Hemodynamics. Systemic BP is 122 by 80 Hg. Pulmonary artery pressure is 20 to 25 mmHg. Due to large pressure difference, blood flows from aorta to pulmonary artery during systole as well as diastole. So continuous murmur will be there. So you understand. So in pulmonary artery, the pressure is 20 to 25 mmHg. Now when there is large pressure, blood flows from aorta to pulmonary artery during systole because there is patency, and then it will go to pulmonary artery, and then murmur will be there. LA, LV and PA enlarge first. So left atrium, left ventricle and PA is what? Pulmonary artery. They enlarge first. Hemodynamics is similar to post tricuspid shunt BSD, and shunt depends on size of the duct, pulmonary vascular resistance and LV function. Eisenmenger's can occur. Eisenmengerization can occur if untreated. So, what is the hemodynamics? So, normal if blood pressure is 120 by 80 and there is only 25 mmHg in pulmonary artery. So, during systole, blood from aorta will go to pulmonary artery and there will be murmur. And now there will be also a lot of workload on LV and LA and pulmonary artery, so they will enlarge. And then hemodynamics is limited to the shunt of depends on the size of the duct and pulmonary vascular resistance and LV function. Eisenmengerization can also occur. Now, what are the clinical features that can occur? Small PDA. If there is only a very small PDA, then usual asymptomatic and detected on a routine examination by murmur. So, doctor, the duct, the patent duct is so small that there are no symptoms. So sometimes doctor will test your heart and then he'll hear a murmur and then he'll say, oh, there could be a patent duct. If there is a large duct, then there will be failure to thrive. That means he'll not be able to gain weight. He will have cardiac failure, he'll have dyspnea, and he'll have frequent chest infections. Why? Because obviously the heart is not able to pump blood enough. So uh, and the blood will also go to pulmonary artery, so pulmonary artery will go to lungs, and then the lungs will be filled, and then he'll have dyspnea, and there will be fluid in the chest, so there will be chest infections, cardiac failure, because obviously LV is increasing, LA is increasing, large volumes and pounding pulse. So the pulse volume will be high and it will be pounding, wide pulse pressure and prominent carotid pulsation. So carotid pulsation will be prominent, and there will be wide pulse pressure, and there will be murmur. Murmur will be heard, wide pulse pressure and large volume. So what is the differential diagnosis? If there is murmur, there could be venous hum, AP window, bronchopulmonary collaterals in TOF, and truncus arteriosus. What all things? Venous hum, AP window, bronchopulmonary collaterals in TOF, and truncus arteriosus. But that is differential for murmur. What do we see in this thing? Apna PDA. What you'll see murmur, you'll see wide pulse pressure and prominent carotid pulsations. If you keep your hand on the neck, you'll see prominent pulses, and then there will be large and bounding pulse. Signs of pulmonary hypertension like VSD, P2 not appreciated even with pulmonary hypertension. So even if there is pulmonary hypertension, usually P2 heart sound is heard, but it will not be heard. And then there will be pulmonary hypertension like in VSD, and mid diastolic murmur in mitral area indicates left to right shunt. So if there is mid diastolic murmur in mitral area, then there will be left to right shunt. Now we'll discuss what is the typical murmur of PDA. The site is in second left intercostal space, second. The type will be continuous murmur. Intensity will be variable, grade 1 to 5 or 6, maybe with thrill. So there will be thrill. Grades can be from 1 to 5. It will be on the second intercostal space on the left side, and it will be continuous. Quality is machinery murmur. Transmission will be at the back. Mechanism: continued blood flow in systole as well as diastole because of large pressure difference between aorta and pulmonary artery. So there will be continued blood flow because of pressure difference, and additional murmur, mid diastolic murmur in mitral area if shunt is large. So mid diastolic murmur will be seen that it will be continuous of type. It will be heard in second intercostal space. It will be ready. It will be filled in the back. Quality is machinery murmur and variable. So what all things you will see in clinical features? You will see that uh, there is wide pulse pressure, carotid pulses are seen, and throbbing or bounding pulse is seen. There is large volume, there is murmur, and there is pulmonary hypertension. P2 is not heard even after pulmonary hypertension, and if there is mid diastolic murmur, then there will be mitral area. In investigations, you'll see ECG, left ventricular dominance, LAD, and LVH. You'll see LAD and LVH, and in CXR, cardiomegaly, you'll see LV type apex, hyperdynamic pulmonary plethora, and enlarged supracardiac aortic shadow. So what you'll see, left ventricular dominance you'll see in ECG, you'll see LAD and LVH, and in CXR you'll see cardiomegaly, because all of obviously if LA, LV, PA all are increasing, cardio heart size will increase only. Left ventricular type in apex will be seen, hyperdynamic pulmonary plethora. 2D echo with Doppler will do. 2D echo with Doppler, CXR, and ECG. Then complications will be CHF, recurrent pneumonia, Eisenmengerization, that is a reversal of shunt right to left. Similar natural course of VSD may occur at earlier age if large PDA, infective end arteritis. What all things can happen? So if a patent ductus arteriosus remains, then what will happen? The child will come with recurrent pneumonia, infective end arteritis, Eisenmengerization, that means reversal of shunt from right to left, and then CHF. What is the management that you'll do? If it is a preterm child, then you'll give indomethacin because it will be, what responsive to that. So 0.2 to 0.3 mg per kg PD is likely to close spontaneously in preterms within 48 to 70, 48 to 72 hours after birth, effective up to 2 weeks age, indicated if hemodynamic is significant PDA with heart failure, respiratory distress. Side effect is renal impairment and platelet dysfunction. Contraindicated if renal insufficiency and bleeding tendency. Indomethacin you cannot give if there is renal insufficiency or bleeding tendency. You'll have to give it within 48 hours to 72 hours after birth. It is effective up to 2 weeks of age, and it is indicated if hemodynamic is significant PDA with heart failure. Paracetamol can be used, ibuprofen can be used, fluid restriction and prevent hypoxia, and treatment of CCF with diuretics and digoxin are needed. Well, so for CCF, you'll give diuretics and digoxin. Term newborns, indomethacin, ibuprofen would never work due to structural different PDA than preterms. May close spontaneously up to 1 month after birth, and surgically ligation even in large PDA can be deferred unless heart failure refractory. Medical so surgical ligation even in heart PDA can be unless heart failure refractory. Means if heart failure is not then there is no need of even surgical ligation. May close spontaneously. Medical management with treatment of CHF, respiratory infections such as VSD. Timing of surgical closure means large PDA with PAH. Then by 3 to 6 months, moderate PDA 6 to 1 years, and if small then 12 to 18. So there's a lot of time. You can do it between 3 months to 6 months if there is large. If it is moderate, then 6 months to 1 year, and if it is small, then 12 months to 18 months. Mode of closure, device closure, coil occlusive devices, or surgical ligation. What all things you'll do? You'll do coil occlusion, coil and occlusive devices, and then you'll do surgical ligation. If PDA is open after 3 months or is large, it is unlikely to close. If presence of PDA itself is an indication of surgery. Pulmonary hypertension is not contraindication to surgery unless isomangarization has occurred. Prognosis, surgical outcome is excellent and surgical mortality is nearly zero. Risk of endocarditis until 6 months after surgery. So no prophylaxis after 6 months of surgery. Thank you guys.